benign lesions of the cervix. We look at the malignant lesions in another video, but for this presentation we look at cysts, tumors like polyps and fibroids, infections, congenital malformation, cervical pregnancy, misplaced intrauterine device, first trimester screening for preeclampsia, cervical stenosis, and prolapse. The normal cervix is homogeneous in ecotexture and similar in echogenicity to the uterine body, with a hypoechoic central canal. Although not always the case. This is a transabdominal image, a full bladder, anterior lip of the cervix, posterior lip of the cervix, external os, cervical canal, internal os, cervical mucosa, and cervical stroma. So this case was that of a hypermobile uterus. You can see the anterior wall of the cervix, the posterior wall, the cervical canal, the cervical mucosa, and the stroma of the cervix. This is a 3D rendered image. Someone described the cervix as the door to the uterus. So this is the door to the uterus. The vagina, anterior lip of the cervix, posterior lip of the cervix. Here you can see the posterior fornix, closely related to the pouch of Douglas. Note the differential echogenicity between the cervical mucosa and the stroma. Where the mucosa ends cephalate is the internal os, and where it ends caudally is the external os. So the cervical mucosa defines the beginning and the end of the cervix. This is a video of the cervix, also demonstrating this freely mobile bowel, suggesting that there are no adhesions posteriorly. In such a case, there is no need to demonstrate sliding sign posteriorly, because this suggests that there are no adhesions. The bladder reflection, the vagina, posterior fornix, posterior wall, anterior wall, external os, cervical mucosa, internal os. This should not be mistaken for Napoleon cyst, because it is not. This is the external os. Here we can see the anterior lip of the cervix, or anterior wall of the cervix, posterior wall of the cervix, the cervical canal, and an abortion follicle. This is a translabial image in a patient who has had cyclage. Not this shadowing around this area. The shadowing is from the rectum. You can see that because of the shadowing, one cannot clearly define the extent of the cervix here. The external os cannot be clearly seen. This is one of the drawbacks of translabial ultrasound scan. In about 20% of cases, the external os cannot be visualized. Now, looking at the benign lesions. The commonest benign lesion of the cervix is Nabatean follicle or cysts. They are usually single, but here you can see multiple Nabatean follicles, clear contents, as you can see, and they are often avascular. You can see Nabatean cysts with distal enhancement. Here you can see the Nabatean cysts with turbid content, but this turbid content could be as a result of the high gain. Here you can see very clear content, that's multiple cysts, and also distal enhancement. Again, here you can see small Nabatean follicle with distal enhancement. Cervical polyp. This video demonstrates the origin of this polyp arising from the endocervix and not from the endometrium. This is the power of color Doppler. So you can see this feeder vessel. Look at the origin of the feeder vessel, suggesting to us that the origin of this polyp is from the endocervix and not from the endometrium. Look at the still image. Origin of the polyp, not the infected polyp, and the origin is from the endocervix as seen here, not from the endometrium. This was a case of postmenopausal bleeding in a 65-year-old using gel sonovaginography. Look at the posterior wall of the vagina, anterior wall of the vagina, anterior of the cervix, posterior of the cervix. Not this echogenic polyp with 6 thick spaces. Initially, I thought it was endometrial polyp because of the echogenicity, but studies have shown that endometrial polyps, I beg your pardon, cervical polyps are also more echogenic than the cervical mucosa. So, and look at the power of color Doppler. The color Doppler delineated the origin of this polyp as endocervical and not endometrial polyp. Same case, 3D rendered image. The vagina. Look at this mass protruding into the vagina from the cervix. So this was a case of broad ligament fibroid and not a cervical fibroid. Bladder, anterior wall of the cervix, posterior wall of the cervix, a hypoechoic central canal is a hypoechoic central canal, and this is the presenting part. So bladder, cervical, hypoechoic cervical canal, echogenic cervical mucosa, and the less echogenic cervical stroma. Not the pericervical fascia posteriorly, and beyond that you see this huge solid heterogeneous mass with stripy shadows, broad ligament fibroid, which led to emergency cesarean section due to poor progress in labor. In cervicitis, the cervix shows a diffusely heterogeneous ecotexture of the cervical mucosa and the stroma. But the key finding is a markedly increased vascularity. This patient presented with features of acute pelvic inflammatory disease. As you can see, the vaginal discharge here clearly delineated the posterior fornix, posterior lip of the cervix, the anterior lip, and the external os. 10 days after antibiotic treatment, the heterogeneity was still the same. So it's not only in cases of cervical cancer that there's increased vascularity. The key finding also in cervicitis is markedly increased vascularity. This is comparing a normal cervix, which is homogeneous in ecotexture, with a case of cervicitis which is heterogeneous in echo texture. This was a case that I used gel sonovaginography after a speculum examination where I demonstrated cervical ectropion. So on gel sonovaginography, I observed this bump, which corresponded to what I observed clinically. So this could be cervical ectropion. Again, with gel sonovaginography, one vagina here, the second vagina, in between you have this longitudinal vaginal septum. So double vagina. Here on transverse section, you can see double cervix, and at laparotomy, double uteri. So uterine diadelphys. This is low implantation. You can see normal cervix here, but here, if you draw this line, the gestational sac is below this line. So this is cervical pregnancy, while this is low implantation. Normally sighted intrauterine device, the cervix is empty. There is a complete reversal of what you see here. Empty fundus, and the IUCD is in the cervical canal. Another case of IUCD in the cervix, and not these multiple perforations. Cervical perforation and lower corporal perforation. The landmark to identify the uterine artery is the cervix around the region of the internal os. To screen for preeclampsia in the first trimester, it can be done in the sagittal view, as in this case, or in the transverse view, as in this case. And this is a spectral Doppler display. This was a case of cervical stenosis. A forced passage was created in the course of trying to dilate the cervix. This asterisk represents hematoma. The B here represents a catheter balloon in the pouch of Douglas, instead of it being in the uterine cavity. A second attempt was carried out under ultrasound guidance, and not the correct placement of the catheter balloon within the uterine cavity. This was a case of suspected endometriosis, but at laparoscopy there were no findings suggestive of endometriosis, but not this blood collection between the internal and external os. Commonly, cervical stenosis is around the internal os, but in this case, you can see is around the region of the external os. These are 5 cases of cervical cancer, all with hematometria, as you can see. In this case, you can see hematometria here, and grade 3 bladder infiltration, hematometria, 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 all as a result of cervical stenosis. This was a 57-year-old who presented with pelvic organ prolapse, not the position of the fundus of the uterus here. This area is occupied by the bowel, and not the displacement of the cervix downwards into the vagina. Again, using gel sonovaginography, not the increased blood flow to the posterior lip of the cervix. Here also not the prolapse of the anterior wall, clearly delineated because of the gel sonovaginography. So thank you very much for listening.